Committee on Homeland Security will come to order. The committee is meeting today to receive testimony on Beyond the Checklist, addressing shortfalls in national pandemic influenza. Good morning. I'd like to take this opportunity to thank the witnesses on both our panels for appearing today, and I'd especially like to thank and welcome Dr. Tony Cirillo from my home state of Rhode Island, who will be participating in the second panel this morning. Let me just say I appreciate your willingness to help Congress understand the devastating nature of pandemic influenza and to work with us in determining what resources are necessary to help prepare the nation before a pandemic occurs. Today, we'll explore what it takes to prepare for and respond to an influenza pandemic that would affect every sector of society and every person in the world. Planning is problematic to begin with because it's so difficult to fathom both the potential casualties and the impact of such a pandemic. Even when we focus just on our own country, the projected numbers are still staggering. 200,000 dead, 2 million ill, all sectors and every aspect of the infrastructure negatively impacted. Though this is a problem that we will not be able to control through standard disease management practices, we can and must rise to the challenge. Make no mistake about it, we are due for a severe influenza pandemic at some point for a variety of reasons. The influenza viruses that could result in a pandemic are increasing in virulence. Record numbers of humans are now living in proximity to current and potential animal carriers. Rapid transit moves people and cargo at increasingly faster rates, fostering the movement and transfer of diseases. Influenza viruses are already mutating faster than we could have imagined, and the toll that avian influenza is taking in other countries is already devastating. The impact this disease could have on the security of our homeland is indeed worrisome, which is why awareness and preparedness are critical. Increased emphasis on pandemic planning and preparedness for the United States in recent years has resulted in the generation of the National Strategy for Pandemic Influenza released in November 2005 and its implementation plan released in May 2006. Some departments and agencies within the executive branch have also created their own strategies and distributed resources and guidance throughout the country at all levels of government and to the private sector based on their strategies and the national strategy itself. Although these are positive steps, one thing is clear: the nation is still not ready for an influenza pandemic to occur here or overseas. Today, we'll discuss the insufficiencies in the national strategy and its implementation plan and hopefully find ways to improve upon our current strategies. The implementation plan for the national strategy is composed of hundreds of separate actions, forming a checklist with some 324 items. Although checklists are good tools for getting things accomplished, we can sometimes make checking things off more important than actually achieving the goals and objectives we set for ourselves in the first place. Our nation's leaders are not seeing the big picture. Instead, they're driving our departments and agencies to focus so much effort on checking boxes that there's barely time left to actually combat a potential pandemic. What we need to address the shortfalls in our national pandemic influenza preparedness and get beyond the checklist. Our efforts seem to have gotten stuck at the federal level, but it's time to shift our resources to the states, territories, tribes, and localities. State, territorial, tribal, and local entities have found themselves preparing for a pandemic without adequate funding, necessary resources, strategy-driven guidance, or strong leadership. When pandemic influenza hits this country, our public health professionals and healthcare practitioners will be fighting to save lives, and the federal government will be assisting in those efforts. We need to cater to them, not the checklist. Today, we'll also examine the interactions among the members of the executive branch, especially the Department of Homeland Security and the Department of Health and Human Services, as they co-lead activities to manage an influenza pandemic when it does strike our nation. Unfortunately, there is little evidence that either agency knows what their roles and responsibilities would be during an actual event. I very much fear another Hurricane Katrina situation where delays in identifying principal federal officials resulted in the significant problems and unnecessary losses of life. We cannot afford for this to ever happen again. We must therefore work the uncertainties out today so that we can properly deal with these situations tomorrow. I very much appreciate the efforts put forward by our federal and non-federal colleagues in the private and public sectors, and thank you all for being here this morning. With that, the Chair now recognizes the ranking member of the subcommittee, the gentleman from Texas, Mr. McCall, for the purpose of an opening statement.
I thank the Chairman. I'd like to welcome our distinguished panel of witnesses here today, and in particular, Dr. David Lakey from my hometown of Austin, Texas, who will be on the second panel here today. In the 109th Congress, this committee held hearings and a series of briefings which examined the national strategy for pandemic influenza and its implementation plan. Today, we are more than a year after the implementation plan was released, and we ask whether we are more prepared today than we were then to deal with the potential onset of a pandemic. I hope the answer is yes, that we are more prepared. I think the answer is yes, but there's certainly more to be done. Never before has a human population anticipated and prepared for a pandemic. Now, we cannot be certain that our efforts are enough, or if they are even realistic. But we do know that we are long overdue for an outbreak of influenza. This 20th century witnessed 3 separate pandemics that cost hundreds of thousands of lives. And we understand that the efforts we make now to prepare for a pandemic, whether it is caused by the H5N1 strain or some other yet unidentified strain, will shape the scope of that pandemic and may save countless lives. The release of the national strategy and the implementation plan were certainly, in my view, a step in the right direction. I agree that pandemic preparedness efforts should go beyond merely checking the box of the action items in the plan, and that a comprehensive and flexible approach should be adopted. I don't want us to overlook the significant accomplishments, however, that the federal government has made in its efforts to plan for a pandemic. We are working with our international partners to limit the spread of H5N1 overseas in hopes that it will not reach the United States. We are expanding our vaccine development capability and stockpiling antiviral drugs, which will be critical at the onset of the pandemic. Plans have been made to increase surge capacity at medical facilities and to continue the operations of government and private sector business during high rates of absenteeism. But we must not be complacent. It is important that the relevant players clarify and test their leadership roles and responsibilities for a pandemic situation. It is also important that others involved in the pandemic planning process, including state and local governments, understand their roles. And while the media coverage of this issue has certainly waned, the threat posed by the emergence of a pandemic influenza to Homeland Security has not. I'm happy to see that this committee is continuing its examination of the pandemic preparedness in this Congress, and I want to thank you, Mr. Chairman, for holding this hearing, and I yield back.
I thank the gentleman. This is obviously a very busy day on the Hill. We'll have members coming in and out and several markups going on, but other members of the subcommittee are reminded that under the committee rules, opening statements may be submitted for the record. And I now welcome the first panel of witnesses. Our first witness, Ms. Bernice Steinhardt, is the Director of Strategic Studies at the United States Government Accountability Office. Our second witness is Dr. Tillman Jolly. Dr. Jolly is the Associate Chief Medical Officer for Medical Readiness in the Office of Health Affairs at the Department of Homeland Security. And our third witness is Dr. Craig Vanderwagen, Assistant Secretary for Preparedness and Response at the Department of Health and Human Services. Dr. Vanderwagen was the senior federal health official in the response to Hurricane Katrina and Rita. We thank all 3 of our witnesses for their service to the nation and for being here today. We look forward to your testimony. Without objection, the witnesses' full statements will be inserted in the record, and I now ask each witness to summarize his or her statement for 5 minutes, beginning with Ms. Steinhardt. Welcome.
Thank you very much, Mr. Chairman and Mr. McCall. We really appreciate the opportunity to be here today to talk about our recent report on planning for potential pandemic influenza in the United States. Fortunately, the administration has taken an active approach in preparing a national pandemic strategy and implementation plan. But we found that much more needs to be done to make sure that federal leadership roles are clear and that the plan is viable and can be effectively implemented. Let me turn to leadership roles first. The plan assigns shared leadership roles to the Secretaries of Health and Human Services and Homeland Security, the first for medical response in a pandemic, and the DHS Secretary for overall incident management and response. But given that a severe pandemic would entail not only a medical response, but would also have to focus on sustaining critical infrastructure and the economy, it's not clear when in a pandemic the HHS Secretary would have the lead and when the DHS Secretary would have the lead. And these two are far from the only leadership positions. Under the Post-Katrina Reform Act, which was enacted subsequent to the pandemic strategy and plan, the FEMA administrator has now been designated the principal domestic emergency management advisor to the President. And also after the pandemic plan was prepared, the DHS Secretary pre-designated a national principal federal official, or PFO, and created 5 pandemic regions, each with a regional PFO and a federal coordinating officer, or FCO, all of them responsible to some extent for coordinating federal planning, exercise, and support. Not only is this leadership structure complex and potentially confusing, it's never been tested. As this committee well understands, as your remarks indicated, Mr. Chairman, one of the major lessons the country learned from Katrina was that plans and assumptions have to be understood, they have to be tested, and the lessons learned incorporated into plans before emergencies occur. Yet the only national pandemic exercise to date was a cabinet-level tabletop simulation in December 2005, well before the National Implementation Plan was released and the leadership structure created. I want to turn now to our assessment of the National Pandemic Strategy and Plan. Although the plan did a good job in defining the problem and discussing constraints and challenges, it's missing some significant elements. I want to highlight just a few here. For one thing, the plan does not identify what it will cost to carry out. Obviously, our ability to do all that the plan outlines is going to be affected by our ability to pay for it. Not everything is going to be easily addressed through existing mechanisms and could, in fact, place considerable stress on existing resources. We're also concerned that despite the fact that state, local, and tribal entities will be on the front lines of a pandemic, these stakeholders were not directly involved in developing the strategy and plan. And lastly, we noted that there's no provision in the plan for monitoring and reporting on progress and for updating the plan to reflect lessons learned from exercises or changes in leadership responsibilities or other policy decisions. To address these gaps, we outlined several steps. First, we recommended that the HHS and DHS secretaries work together to develop and conduct rigorous testing, training, and exercises for pandemic influenza. We also recommended that the Homeland Security Council establish a specific process and time frame for updating the plan, one that involves key non-federal stakeholders and fills in other gaps that we identified. I would note that HHS and DHS agreed with our recommendations, but the Homeland Security Council did not respond or offer comments on the report. I want to say in closing that these gaps are not trivial or simply procedural. When a pandemic actually occurs, the effectiveness of actions that are taken at the outset are going to be of critical importance in helping to limit the spread of the disease. While we recognize that our understanding of the virus is still evolving, it's important to take these steps now before disaster strikes. With that, I will conclude my remarks, and I look forward to your questions. Thank you.
Thank you for your statement. I now recognize Dr. Jolly to summarize his statement for 5 minutes. Welcome.
Thank you, Mr. Chairman, Ranking Member McCall, and members of the subcommittee. Thank you for the opportunity to testify before the subcommittee to discuss the progress of the National Strategy for Pandemic Influenza and its implementation plan. Before I begin, I would like to take this opportunity to thank you and members of the full committee on behalf of Secretary Chertoff for your continued willingness to work alongside the Department to provide leadership in protecting and ensuring the security of our homeland. I would also like to thank our partners at the Department of Health and Human Services and others with whom we work every day. The pandemic is unique. It is likely to come in waves, passing through communities of all sizes across the nation and the world simultaneously. The pandemic may last as long as 18 months. An unmitigated pandemic could result in 200,000 to 2 million deaths in the United States, depending on its severity. Further, an influenza pandemic could have major impacts on society and the economy, including our nation's critical infrastructure and key resources based on illness and related absenteeism. DHS has been and remains actively engaged with its federal, state, local, territorial, tribal, and private sector partners to prepare our nation and the international community for an influenza pandemic. As outlined in the implementation plan, DHS is responsible for the coordination of the overall domestic federal response during an influenza pandemic, including implementing policies that facilitate compliance with recommended social distancing measures, developing a common operating picture for all federal departments and agencies, and ensuring the integrity of the nation's infrastructure, domestic security, and entry and exit screening for influenza at the borders. In working with our partners, such as HHS, the State Department, and USDA, DHS has developed and implemented a number of initiatives and outreach to support continuity of operations planning for all levels of government and private sector entities. I will highlight a few noteworthy accomplishments and responsibilities under the implementation plan particular to DHS. DHS produced and released the Pandemic Influenza Preparedness, Response, and Recovery Guide for critical infrastructure and key resources. The guide has served to support business and other private sector pandemic planning by complementing and enhancing, not replacing, their existing continuity planning efforts. With that in mind, DHS and its partners developed the guide to assist businesses whose existing continuity plans generally do not include strategies to protect human health during emergencies like a pandemic. As a next step, DHS is currently leading the development of specific guides for each of the 17 critical infrastructure and key resource sectors using the security partnership model. In coordination with other federal departments and agencies, DHS is developing a coordinated government-wide planning forum. An initial analysis of the response requirements for federal support has been completed. From this analysis, a national plan defining the federal concept for coordinating response and recovery operations during a pandemic has been developed and will be undergoing interagency review. Utilizing this planning process, a coordinated federal border management plan has been developed and is currently also in review. This process included a wide range of partners. DHS has also conducted or participated in federal and state interagency pandemic influenza exercises and held workshops and forums with critical infrastructure, key resources, owners, and operators. Consistent with his role under Homeland Security Presidential Directive 5, Secretary Chertoff pre-designated Vice Admiral Vivian Cray, the Vice Commandant of the U.S. Coast Guard, as the National Principal Federal Official, or PFO, for pandemic influenza and has pre-designated 5 regional PFOs and 10 deputy PFOs. Likewise, our partners have pre-designated infrastructure liaisons, federal coordinating officers, senior officials for health, as well as defense coordinating officers. Vice Admiral Cray and the regional PFOs have participated in multi-agency training and coordination sessions regarding preparedness duties. Additionally, the PFO teams have begun outreach both nationally and in their regions in advance of a more formalized exercise program which is being developed by DHS. On an ongoing basis, DHS participates in interagency working groups to develop guidance including community mitigation strategies, medical countermeasures, vaccine prioritization, and risk communication strategies. In closing, significant progress has been made in national preparedness for pandemic influenza. In fact, September is National Preparedness Month, which encourages all Americans to prepare for emergencies and take necessary actions for all hazards. DHS looks forward to continuing its partnership with the federal interagency, state, local, tribal, territorial, and private sector stakeholders to complete the work of pandemic preparedness and to further the nation's ability to prepare for, respond to, and recover from all hazards. Thank you again for the opportunity to testify on behalf of the Department of Homeland Security on these issues of critical importance to our nation's security and well-being. I'd be happy to answer any questions you might have.
Thank you, Dr. Jolly, for your testimony. And I now recognize Dr. Vanderwagen to summarize his statement for 5 minutes. Welcome.
Thank you, Mr. Chairman. And it is a great opportunity to come and visit with you about the partnership between the legislative and the executive branch that I think we've moved forward aggressively on over the last couple of years. As you may know, the Assistant Secretary for Preparedness and Response was established approximately 10 months ago under the Pandemic and All Hazards Preparedness Act. We had significant responsibilities transferred to us and significant new authorities. We have tried to execute those in a very timely manner. We've transferred NDMS, we've transferred the Hospital Preparedness Program, we've transferred the ESAR VIP program. We have taken on new authorities under BARDA. We're standing up the National Biodefense Science Board, and the list of accomplishments requested under the law we would be happy to share with you in detail if you are most interested. However, I would note that in August, there was a transfer of responsibility to the ASPR from the Assistant Secretary for Health for pandemic planning and coordination within HHS. So I'm here today to speak specifically about pandemic flu, and you have articulated, I think, most succinctly the threat, the risk, and what the challenges are. I believe that over the last year there has been significant progress. I agree with Mr. McCall. There has been significant progress jointly among the states and the federal government. There was a strong federal lift strategically planned to purchase the ability to develop and deliver vaccines as part of our overall strategic goal. And as was noted by both of you, our strategic goal here, our theory of victory, is a delay of this disease spread and the reduction in the absolute number of individuals who will be affected by the disease. And the first-line investments to assure that included the development of domestic capability in the production and delivery of vaccines and antivirals and diagnostics that would allow us to be very astute in the way we employed those techniques in reducing the rate of infection. But as has been noted, it is also now time for us to review and update what are the gaps that still persist and what are the challenges that are ahead. Our belief is it should be built upon some of the success that has occurred. Accordingly, with our vaccine investments and our investments in newer antivirals and in diagnostic capability, we are monitoring those production capabilities, and we have set up milestones for that performance of activity and our funds that we have remaining, and we've spent about $3 billion or so. The balance of funds are established as a reserve to continue that progress and development as they achieve certain milestones. But there are persistent gaps, as I said. Those gaps exist in respiratory protection. They exist in how we can make community mitigation even more effective, potentially using the expanded production capability in antivirals to perhaps use antivirals in a prophylactic mode as opposed to a pure treatment mode, which is where our previous investments have been. These next steps, however, have to be built upon the concept of shared responsibility. Again, as you both stated, the role of state and local governments, of business, and indeed of individuals and families needs to be explored further, and their engagement in the gap-filling process needs to be active and needs to be present. We've started that process here in the last couple of months and have met with business interests, public health interests, medical interests in Seattle, in Raleigh. We have other opportunities planned ahead for engagement of those stakeholders in this process, and we think that that will help us to determine how to divide this shared responsibility for development of approaches to meeting those gaps. There's a sustainment challenge that also lies out there in front of us as well, because what we build today has to be sustained over time, and those issues will need to be addressed. If not right this minute, they will need to be addressed in the way ahead. So in summary, ASPR has stood up. We accept the responsibility. We work closely with our partners and view ourselves as being an integral part of the team led by DHS, but our shared responsibility demands that we reach out to our stakeholders at the state, local, family, and individual level if we're going to move ahead with the new steps that remain to be addressed. And with that, I will stop and be happy to address questions.
Thank you, Dr. Van der Wagen. I thank all the witnesses for their testimony. Each of the members will have 5 members to question the panel, and I now recognize myself for questions. Again, I want to thank you all for your testimony. Let me address a question to the panel. To me, it would seem that an effective system of planning a response to pandemic influenza is one in which it would have broad-ranging benefits in other areas of public health threats, whether naturally occurring or man-made. So my question would be, how does pandemic flu planning help in other ways, and what are we doing to ensure that it's helping in other ways? Again, it would seem to me that we should be thinking about this as we develop plans so that we might spend dollars more efficiently.
I'll begin, sir. I think that you're correct. There are a number of ways in which a pandemic planning process can assist other planning processes. In the health focus, which I think Admiral Van der Wagen will focus on, there are certainly some areas of synergy. And outside of the purely health realm, when we think of operations of critical infrastructures, continuity planning, and complex organizational structures that may be required for complex crises, the pandemic planning we've done related to those issues certainly can help those. There are some unique aspects, as we've discussed with pandemic, the length of time that it lasts, the wave nature, and some of the specific issues. But some of those continuity planning processes and the operational planning at the federal level certainly apply to those, and we've really taken the tack now of trying to apply those to a broader set of hazards.
Yeah, I agree with Till wholeheartedly, and I'll just give you one example. And sir, I've been to your state, Rhode Island, and visited the Rhode Island Medical Center, visited with the staff up there. There are great examples of how all hazards preparedness, as applied to pandemic or any other disaster, are demonstrated, and I expect that we'll hear some of that today. This first part of the week, I was down in North Carolina for a couple of days visiting with them around their planning. And last year alone in North Carolina, they conducted 87 exercises for pandemic flu. But what was clear was that they were using assets that they would deploy and involve in just about any sort of hazard. Hurricane is one that they live with frequently there in North Carolina. But the exercises, while focused on pandemic flu and some of the unique qualities, as Till suggested, they were exercising the whole system, the communication between public safety and health, the delivery of assets to communities, and that could be for any infectious disease or other demand. So I think there's some great examples where the states and localities really are using pandemic to build an all-hazards response base while having the unique capabilities for pandemic.
If I can just add to Dr. Van der Wagen's comments, the important thing in any emergency that requires the enormous amount of coordination across multiple sectors and multiple actors is building those relationships before emergencies occur. You can't start getting to know people in the middle of an emergency. So having those relationships in place, understanding who one is supposed to turn to, all of that is very vital to being able to respond effectively in an emergency. And so any kind of planning and exercising that forges those relationships is going to benefit us in any emergency.
Let me follow up with this. Some would argue that the grant strategy, the grants that are offered to states, for example, are not well coordinated, in that you can spend money if it's for preparedness for pandemic flu, but you're not able to spend that money in other areas that where we would be part of the response system to a public health threat. And some would argue that there's not good coordination in how you're writing and offering grants to states and in other areas. So can you comment on that, the coordination between DHS and HHS grants, for example?
Yeah, and there is a real risk there of a disconnect in bureaucratic silos at play. But I think that the most recent amount of money that we provided to the states, $75 million for pandemic flu, included guidance that would allow them to purchase assets that have utility in other than pandemic flu. Ventilators, for instance, may be useful in a variety of settings, not limited to pandemic flu. In terms of engagement with our DHS colleagues, and again, I'll give you a North Carolina example, they were looking to develop a paratransit capability for evacuation of patients with special needs. And what they were able to do was merge USERA grants, CDC grants, and the ASPR hospital preparedness grants, using the authorities of each one of those to put together a package that would allow them to purchase and have constructed the appropriate paratransit equipment. It takes extreme work and communication on our part at the federal level, but I think the states that have been most successful also take a collaborative internal approach to this, where they look at all the grants and they look at how they can use it for the ends that they're really trying to achieve. So I think it takes work at both the federal level and the state level to try and make those work effectively together.
And I would concur with Admiral Vanderwagen and Ms. Steinhardt that the opportunities in pandemic preparedness based on the grant funding for pandemic really play out in overall all hazards preparedness, giving public health, emergency management, security, law enforcement, all the elements that come to play in complex crises, an opportunity to sit down together and go through scenarios, while mostly focused on pandemic in this case, allow them to get to know each other, get to know their various needs and the unique aspects of their roles, and help to coordinate those, and can only have benefits for other crises.
I hope to be able to answer your question better in a few months, because we're actually looking at these issues of state and local planning and exercising currently in an ongoing engagement for this committee. But I want to say now that one of the things we've observed is that this is a long-standing, I think, challenge to better integrate not only the funding, but the communities themselves of public health and emergency management. They still speak different languages. They have different vocabularies. They're getting to know one another. And I think around pandemic planning is the immediate task at hand, but it will work in other areas as well.
Thank you. Let me turn to the GAO, to Ms. Steinhardt for a minute. I was troubled when I read in the GAO's report on the national strategy that both the Secretary of Homeland Security and the Secretary of Health and Human Services would be co-leaders during an influenza pandemic, but that how they would actually lead at the same time has not yet been made clear. You made reference to this in your opening statement. Could you expand on this finding?
This is a kind of new model for us in the federal government to have these shared responsibilities. I think it's appropriate to recognize that for the major challenges like a pandemic influenza that face the nation, that it does take the efforts of multiple departments and competencies. But how exactly that works still has to be figured out. That's why we argued so strongly for having tests and exercises. Only when you go through a simulation of an actual situation can those kinds of details be worked out. We understand it conceptually, but how it would work in practice, we need to see.
As a follow-up, Dr. Jolly and Dr. Vanderwagen, during a pandemic, when would the Secretary of Homeland Security lead, and when would the Secretary of Health and Human Services lead?
Well, under the construct, the Secretary of Homeland Security is responsible for overall overall domestic preparedness and incident coordination at the federal level, and would lead the overall federal activities, while the Secretary of Health and Human Services led the health and medical response, which is a very large job just by itself. And our PFO group, our Principal Federal Official Group, working with HHS, FEMA, our Operations Directorate, and others, are working through the exact specifics of how that works down at the lower levels.
Yeah, I agree with that. We, I think, understand ourselves as having a finite and discrete responsibility under the overall leadership of DHS. Where this becomes an incident that has national significance, there's no question. The leadership resides with the Secretary of Homeland Security. With regards to public messaging, with regards to strategic thinking about application of assets to the medical and public health piece, we have that responsibility, but that still resides under the overall leadership of the Secretary of Homeland Security. And the constructs, that is the actual operational planning, is as Till has described, and I think Ms. Steinhardt did as well. That operational construct is now being established, and in fact we've tested it some in that Vice Admiral Cray and some of her folks have participated in CDC exercises around pandemic flu to begin to see how the health piece nests under her leadership.
Well, this is obviously an area we want to continue to watch and to be involved, and obviously we can't wait until an actual event occurs and hope that, you know, the left hand knows what the right hand's doing. And as Ms. Steinhardt pointed out, you know, conducting exercises and actually simulating this is really the best way to make sure it's going to function properly when in the event that when a national emergency like this would occur. With that, I now recognize, well, actually before they do that, let me just welcome the gentleman from New Jersey, Mr. Pasquale, who has joined us and was a original member of the Homeland Security Committee when it was a select committee, and left for a brief time when he went on the Ways and Means Committee, and now he's back joining us, as well as being on Ways and Means, also on the Homeland Security Committee. Welcome back, Bill. The chair now recognizes the gentleman from Texas for 5 minutes for purpose of questions.
I think the chairman, I too want to welcome back Mr. Pasquale to the committee. It's good to have you here. As we approach the flu season, it's that joyful time of the year. I get to drag my 5 little children kicking and screaming to the doctor's office and holding them down as they get their flu vaccines. We try to anticipate the next sort of mutation, if you will, in preparation for this vaccine. And overall, I think we've been very fortunate in terms of our ability to predict and foresee. The issue with the pandemic would be a mutation that would be unforeseen, some sort of variation like the avian flu that suddenly becomes transmittable human to human. And that's a scenario that we obviously are most concerned with. And how do we stop it? Is we all know it's been about 40 years since we've had one in this country, and we are long overdue for that. My first question is more science related. So for the 2 doctors that we have, in terms of vaccines, you know, it seems to me that in the event we have a pandemic that's an unforeseen mutation of a virus, the ability to quickly develop a vaccine would be key in terms of minimizing the loss of life. I know that there's been some research now going from egg-based to cell-based vaccines, and I'd like to hear from you in terms of the progress that we've made in that regard, in terms of developing, you know, vaccines that we can get to, you know, in the market more quickly.
Yeah. Well, it's an extremely good question, and one that we've really tried to focus on pretty steadily. Our investments have been with multiple manufacturers to develop cell-based technologies for production in this country. That doesn't provide a tremendous amount of the shortening of the time period from the time the virus is identified until you have a manufacturing capability to put it out there, but it is a cleaner, more modern and sophisticated technology that doesn't depend on chickens for eggs. And in an avian flu, that's, you know, we have biosecurity and so on, but still, it's shifting to that new technology. Where we think there will be the breakthrough in terms of reducing the production time from the identification of virus to the actual production capability of vaccine at production levels is with the development of a recombinant vaccine. And we are about ready to award a contract for a producer of that, and we hope to have a couple producers in that game, not limited to one, that would allow us to see if, in fact, the promise of an 8-week turnaround instead of a 20-week turnaround is as we think it might be. That combined with the developments now in adjuvant therapies added to the antigen. Remember, the vaccine has an antigen that stimulates your immune system. Now the technologies of developing adjuvants that augment that immune response at a much lower dose of antigen. And the research in this area is also very promising. If it plays out, and there are clinical studies underway now to assure that they are safe and effective as advertised, if that works out, it may give us a 20-fold increase in our existing pre-pandemic vaccine stockpiles. And in the future, if we have to produce a new vaccine, it will change the character of how much we need to develop an antigen in order to get a good vaccine with a good immune response. So progress is moving along very smartly in the technology and science arena here with vaccine development for influenza, particularly pandemic flu.
Can you forecast maybe the time frame that technology would be
I think the RPA, that is the recombinant technology for this, proof of concept is out there. We're talking a year or so? 2010, we think we'll have that available, is the way we're thinking about it. The adjuvants that I mentioned to you may occur sooner than that, 2009 perhaps. We'll have final clinical efficacies and everybody will be convinced that we've got the safe product for use.
Dr. Jolly?
We certainly support that. I think the planning and the community mitigation guidance and other strategies take into account the current situation, but we certainly support further research, and I think this argues for a couple of things. One, the vaccine research for pandemic can only benefit vaccine research for other diseases, and I think there's a wide range of things, both in the emergency management realm and just in public health, that this can really help. If this technology works for one, it can certainly work for others. Also applaud and sympathize with your efforts to get your family vaccinated. And that really argues for our increased vigilance and public message to the public about seasonal flu, and to really utilize the seasonal flu vaccine, because seasonal flu is not a trivial matter just by itself.
Well, that's very, I find it to be a very exciting and promising area. And the other, this is also sort of more science-based, but antivirals. Where are we with those? But also, where are we with the stockpiles in the event of an outbreak? Obviously, as you mentioned, Dr. Van der Wagen, about the idea of them being used as both prophylactic and after exposure. Do we have enough, say, Tamiflu and other antivirals? Do we have enough stockpiled right now in the event there is a pandemic outbreak?
Well, let me answer the first part of that first, and that is, where are we? We're on plan. You may recall that we strategically made the decision to purchase enough to treat everyone that we thought would be at risk and got ill. And so the plan investment was to purchase adequate amounts with our state partners to treat 25% of the population who we projected would be ill. We're on plan for that. The last purchases to fill out the 81 million treatment courses for that will occur in fiscal year 08. With regards to the use of antivirals in prophylaxis, we made that strategic decision about purchasing for treatment because at the time production capability was fairly limited, 15 million or so a year treatment courses. Now that production capability is much more robust than that, which gives us the opportunity to visit with our stakeholder partners, the states, businesses, even down to individuals and families, the question of where is the responsibility for shared acquisition if, in fact, the science supports the use? And that is sort of a question that we're analyzing right now. What is the science base for using antivirals in a prophylaxis environment? And what are the risks of doing that in terms of developing resistance, for instance, and therefore losing the utility of the tool? We're also developing additional antivirals, at least one that attacks at the same spot that Relenza and Tamiflu, I'm drawing a blank there, aging, what can I tell you, that is similar in action but can be delivered through the bloodstream parenterally, as we say in medicine, which for extremely sick people would be another alternative that would be very useful. So there are developments on the horizon. There are some gap questions to be answered, both from a science perspective and from a shared responsibility perspective. But if, in fact, the science supported it and we worked out the shared responsibility, there's a potential use there in post-exposure prophylaxis and for those who are at high risk, like medical workers, of acquiring the disease. We know, for instance, in seasonal influenza, 15 to 30% of health workers in hospitals taking care of very ill people with flu get sick. So there's another target population at risk that we need to consider.
Ms. Steinhardt and Dr. Jolly, if you could comment on that as well. Is our stockpile, national stockpile of antivirals adequate to meet if a pandemic occurs this year?
Well, I can't say that we've assessed that specifically, but I think a lot of it has to do with whether we change the use of antivirals, if we're using them just as treatment. And obviously, we don't have enough to treat the entire population, or if we're going to use them prophylactically. But I must say that this is now the opportunity to think about how if we do have limited supplies, whether of antivirals or of vaccines, if we were to have pandemic influenza in the nearer term, what sort of priorities are we going to set for distributing those supplies? That's, I think, a key question for us.
I agree. Dr. Jolly?
And I would agree with Craig. We're building up the stockpile, and we're shifting from an analysis that involves purely treatment to potentially a larger amount of that needed for prophylaxis, and trying to develop the science base, because there's no medicine that doesn't have a risk associated with it, and there certainly are risks associated with wide use. And the other point I would make is that antivirals are not the entire answer. We can't, we really want to be careful to make people understand, everyone understand, that having an antiviral isn't necessarily 100% curative or preventative, but in fact, it's incorporated into a wide range of strategies that don't include pharmaceuticals, the community mitigation strategies that were led by the CDC with multiple agencies involved that are really part of the overall strategy.
See, my time has expired, but I want to close with the same point that the chairman made, and that is the exercises. I think there's been one exercise to date. Was that a tabletop or was that a field exercise?
It was a tabletop exercise, and it was before actually the issuance of the plan.
The plan. I would strongly encourage Dr. Jolly, you consider conducting a field exercise in the event a pandemic broke out. I think, having worked with the Joint Terrorism Task Forces in my prior lifetime, I think when you do these things in the field, you kind of get a better sense for who's supposed to be doing what in a real sense. So with that, I'll yield whatever time I have left, which I see is 0.
And then some. But I thank the gentleman, and Jenna recognizes the gentleman from New Jersey for 5 minutes.
Thank you, Mr. Chairman. It's good to be back. I followed this issue very carefully, and I have some questions for the Rear Admiral Vanderwagen. I want to thank you for convening the hearing. I appreciate the administration appearing today. This is very important because I believe that the sense of urgency shown by Congress and the administration has diminished and not increased in recent months, despite the fact that the World Health Organization has now confirmed a total of 327 cases of avian flu and 199 deaths, including recent disturbing reports out of Vietnam and Egypt and Indonesia. To date, I understand the administration has requested and Congress has appropriated $6.1 billion for implementation of the $7.1 billion National Strategy on Pandemic Influenza, including $2.3 billion most recently on the FY06 Emergency Supplemental Appropriations Bill. This administration has been evasive in answering questions about why the funds allocated for the purchase of the antiviral drugs have not been spent to complete the stockpile. I have here in my hand 3 letters. These 3 letters went to Secretary Leavitt from the House Republican leadership in June. 1 letter came from the House Democratic leadership in August. And the last letter is from Senator Thad Cochran, who wrote that letter to the Secretary in September. All of them asked the question, why we have only purchased enough drugs for 15% of the population when the NSPI calls for 25% of the population to be covered by the stockpile. Now, my first question to you, Rear Admiral, is why have these letters gone unanswered?
I can't speak to that, sir. I'll have to ask that question of the Executive Secretariat and the folks who manage the correspondence.
You don't know why the letters have been unanswered?
Specifically,
I mean, they came from all sectors of the campus here, and we still don't have an answer for them. This committee doesn't have an answer for them. The Congress doesn't have an answer for them. Who in God's name do you think you're kidding? Who do you believe will believe on this side of the aisle, excuse me, if I may continue, the urgency of this situation? Who do you think is going to believe you?
let me go back to your first question.
Sure.
I've just been informed that 2 of those that answers have been provided to the Hill for the first 2 of those, and we'll provide documentation of that for you, sir.
We don't have those answers yet, and we'd like to have those answers.
Right.
Do you know what's contained in them?
I haven't seen them myself, no, but I...
In addition, Rear Admiral, how much of the funding allocated to you has been set aside for antiviral purchases? And how much has been set aside for vaccine purchase and development?
Right.
Have all of these funds been spent?
We currently have obligated $3.2 billion, $2.4 billion of that for vaccines, including cell-based vaccines, antigen-sparing activities, facilities retrofitting, international vaccine development, the H5N1 pre-pandemic stockpile. We have a total commitment of $796 million for antivirals. That includes $103 million for advanced development, $523 million for federal stockpiles, and $170 million for state stockpiles. We have an additional $27 million invested in advanced diagnostics.
So how much haven't you spent?
We have a balance remaining that is set aside in reserve for those advances that we have agreed to work with the vaccine companies to do. We're monitoring their progress. We have agreed to milestones, and when they achieve those milestones, we would continue to make investments. That was our business arrangement with those producers, that if they hit certain milestones in production, we would then advance further investments.
Why is it that we apparently had, and there's no seamless solution, we understand that, but why haven't we used our capacity to purchase and stockpile the very drugs we know that work? And we've sent mixed signals to the pharmaceuticals. They're not going to continue to make these unless, you know, we purchase them. And if they've been tried, if they've been tested, it seems to me that we are circumventing the solution, not exercising urgency, and talking about developing another set of solutions, which you know is going to be 3 to 5 years. Let's go back to the history of these things. I don't understand that. Maybe you can help me understand.
The investments that we were to make for antivirals for treatment are on plan. We have stated forthrightly that we would purchase X amount in 2007, and we would purchase the balance of that in 2008. There's been no real change in that plan. That's out there in the marketplace. That's been a consistent message from us. The advanced development investments, we think by 2010 will have payoffs that have huge benefits for the population, as you may have heard me respond to Mr. McCall.
I think that, Mr. Chairman, if I may conclude, my time is up. I really still don't sense the urgency that is necessary that on both sides of the aisle have been expressed and is not being implemented. And I would hope that through the chair to the ranking member, that this could be brought to bear and that we can get the answers that they talk about, these letters, which started 5 months ago. And now we're hearing at this committee hearing that there are answers, but they just haven't gotten to us yet. Would you please follow up on that, sir?
Absolutely.
Thank you.
I can guarantee that to the gentleman, and I thank the gentleman from New Jersey for his questions. You clearly have not lost your passion for Homeland Security issues. Yeah. I thank the gentleman. In consultation with the ranking member, what we'd like to do, there are 2 votes on right now. Hopefully that will go quickly. We'd like to go for a second round of questions with this panel, since many members are at markups and at other meetings right now. We'll go for a very brief second round with this panel, and then go to the second panel when we return. I would say that we should be back here in about 20 minutes. With that, the committee stands in recess.